All right. Well, hello and welcome everyone to the winter 2022 online conversation hosted by the Occupational Therapy and Disability Studies, or OT and DS Network. My name is Elisa Jordan-Sheff, one of the co-founders, and I'm so happy to be here with you this evening. I wanted to make sure and give a brief self-description as we begin. I'm a white cisgendered woman in my early 40s. I have long brown hair and wearing glasses and have on a burgundy top with a beige geometric pattern. I use she, her pronouns. We invite anyone who wants to speak during the discussion to say their name and provide a brief self-description as well tonight. Before we begin, I'm going to take a moment to do some access invitations for tonight's discussion. First, we will be using Zoom auto transcription feature. To access the auto transcriptions, click on the CC or closed caption button at the bottom of the Zoom window, and then click Show Subtitle or View Full Transcript to make captions or the full transcript appear on your screen. We will be monitoring the chat. If you have any accessibility needs, we can help with. We also wanted to let you know that we will be recording tonight's discussion and we'll be posting it to YouTube as an unlisted video. All registrants will be sent the link to view the video once it's ready. We invite you to use this information in a way that feels good to you, whether that be deciding whether you want to be on camera when making decisions about how to participate in the discussion and so on. The recording will be posted under speaker view, and the transcript, once edited for accuracy, will also be posted along with the recording. You will also see that some of us have included our pronouns with our Zoom names. We invite you to do this as well if you wish. You can change your Zoom name and or add pronouns by hovering over the top right corner of your Zoom box and then clicking on the three dots that appear, and then on rename, and then finally editing the text box that opens up. During tonight's discussion, we invite you to move around, stand, stretch, join from bed, or otherwise be present in whatever way your bodies and minds need at the moment. We also invite you to ask questions of our speakers and moderators. You are welcome to unmute yourself and ask your questions aloud or use the chat feature, which we will be monitoring throughout the discussion. We'd also like to get a sense of what your background is and kind of your role in the field of occupational therapy or whatever kind of field you're coming from. So we do have a quick poll for everybody. Folks could take a moment. Okay, and if you just joined us, we have a poll coming up. You should see that you could just let us know if you're a student, practitioner, faculty, researcher. We'll close it in just a moment. Okay. So just so everyone can see kind of what the breakdown is, a little over half students, 15% practitioners, 20% faculty, 5% researchers, and 5% others. So whatever your kind of background or role, we're just really glad to have you here and to have such a group representing a number of different areas. So to give you a little background, the Occupational Therapy and Disability Studies Network is a platform for dialogue, collaboration, and pursuing social justice at the intersections of occupational therapy and disability studies. As you may know, our most recent project was editing and contributing to a special issue of the American Journal of Occupational Therapy on Disability Studies, published in the summer of 2021. Throughout 2022, we are looking forward to bringing you a series of online conversations featuring authors from the Disability Studies Special Issue discussing their work. We hope you'll join us for our spring 2022 conversation featuring the work of Janet and Gill, Gail Teachman, and Ibrahim Richard Bangura on April 26th at 11 a.m. Eastern. A link to the registration and information will be put in the chat. Okay. Again, let us know if that link is not working and we can make sure we get a working link. Today, we are joined by Amy Roder McArthur, who will facilitate a discussion about her article in that special AOTA issue that she co-authored with Carol J. Gill, entitled Building Bridges, Integrating Disability Ethics into Occupational Therapy Practice. This article connects AOTA's Occupational Therapy Code of Ethics with disability ethics, using a case-based example to illustrate how disability ethics can enhance practitioner reasoning and provision of care. We hope you have reviewed the article prior to joining the meeting today, but we will post a link in the chat as well for your reference. And there's that. So it's my pleasure to introduce Amy today. Amy is a PhD candidate in the Disability Studies program at University of Illinois at Chicago, and a current McLean Fellow in Clinical Medical Ethics at the University of Chicago. She completed her MS in Occupational Therapy at Tufts University. She has practiced as an occupational therapist in the settings of acute care, inpatient rehabilitation, subacute rehabilitation, and clinical research prior to starting her PhD program. Outside of her professional pursuits, she enjoys spending time with her two children, Peter and Andrew, and her husband, Ryan. And I'm going to turn it over to Amy now to start the discussion.
Thanks, Elisa. So similar to Elisa, I'm just going to give a little description and then kind of get into a little bit of background about the article. So I'm a white woman. I have brown shoulder length hair, and I'm wearing a black shirt with an orange and white pattern sweater over. And so that's me. To give you a little bit of background about how this article got written, it's actually the product of an independent study class for the Disability Ethics Certificate Program at UIC. And I had gone through the majority of the classes for that certificate program, which is run by Carol up until that point, and then saw that this special issue was getting produced and really wanted to use that as an opportunity to apply what I've learned within the context of my professional background of occupational therapy, and kind of take a time to look back at what kind of ethical discussions exist within the OT literature, and then also see how I can integrate what I've learned so far about disability studies and disability ethics into what I know as a clinician as well. So that was my independent study for the semester that I wrote this, and Carol was really a mentor throughout that entire process, checking in with me on a regular basis, giving me feedback on my ideas, and helping me, look to other resources within disability studies to help me put together the article that you were able to read today. Let's see. So I think one question that I got from the reviewers that I think is relevant to everybody in the discussion is really kind of getting an idea of what exactly disability ethics is. And it's not necessarily a super, set in stone definition, but I think something to be aware of is that it's pretty much a response to bioethics, which kind of came about in response to a lot of new medical technologies that were being used, kind of talking about how medical technology can and should be used. And a lot of the discussion within bioethics is around quality of life, whether or not different technologies should be used to prolong life, to extend life, to save life, et cetera. And a lot of those questions really are questions that relate to disability, and the voice of people who have disabilities or who have an expertise in that area really weren't present in original bioethical discussions. So there was a need to respond and really say that, a life with disability can have a very high quality of life, and that should be something that is considered when discussing use of medical technology and also healthcare provision. Um, so that's just, I think, something to really keep in mind when thinking about this. And then the other thing that I think is helpful to know is sort of um, disability ethics doesn't follow the same structure that we may be used to of seeing ethical principles, or what can be called principlism within ethics literature, which is what the AOTA Code of Ethics really follows. Is they have principles that are derived mostly from two of the really popular ethical voices in bioethics, Beecham and Childress. So you're not necessarily weighing different principles within within disability ethics, but rather coming from the vantage point of life with a disability has quality, and assessing situations based on that. So that's sort of the background. And then what I've done in the field of ethics since writing this article is I am a part of the McLean Ethics Fellowship at University of Chicago, which Elisa mentioned. And that's really been an interesting experience because it's, from what I know, the first clinical medical ethics fellowship in the country, potentially the world. And really it's about applying principles within ethics to practical situations. And that's what the field of clinical medical ethics is. And I think that it's something that I have really valued because I've learned a lot more about how healthcare is delivered in a more global sense. But I think it also brought to mind for me how important the voice of occupational therapy practitioners can and should be within ethical healthcare decision making, because I find often we have a better idea of what somebody can do when supported appropriately, and we can bring that voice to the healthcare decision making team. So that's sort of an introduction. I don't want to just ramble on or give a lecture, so I welcome any questions or comments from people, and I do have more I can talk about, but I'm sure you don't want to just hear me go on and on. So feel free to either chat in information, raise your hand, unmute yourself, whatever feels best for you. Therese Betts, go ahead.
Hi, I'm just trying to put on my camera. My name's Therese Betts. I am a brown woman and I am wearing my hair back in a ponytail and I have on a colorful sweater. I just wanted to ask, so I really enjoyed reading your article. I thought it was very enlightening and I thought that it very much touched on the principles within occupational therapy and how we practice in general from like a client-centered basis. I wanted to ask you if you could just, because I'm in pediatrics, I'm a school-based occupational therapist. So for me, I feel like there's a lot going on in that area. One of the things that come to mind is that, in terms of like advocacy, as your article touched on and talked about, a lot of times the parents are the advocates for their children, or the parents, acquire advocates to kind of, speak and make sure that the best services are being provided, or what they may consider, the best services. And I just kind of wanted to ask you if you could maybe touch a little bit more on disability ethics and how it may apply to not just the school-based setting, but also the pediatric population, because I do feel that, I think it seems like there's some challenges in some ways, but I think that from a OT perspective, we're always trying to, think about the best outcomes and, for our students. But I do think that, sometimes we're always just like looking at it from like a functional, is this functional in the school setting or things like that. So if you could touch on that a little bit more.
Sure.
Sorry, that was a lot.
No, that's okay. So I guess what I would say first, and please, step in if I am saying this in a way that doesn't make sense within your context of pediatric practice. But I think something for me that really was important that came about through discussions with Carol Gill about this was that, a lot of times, and I have fallen victim to this myself as a clinician, we see impairment as inherently a negative, when really it doesn't necessarily have a valence that's positive or negative until it comes into interaction with your environment. And going back to kind of like the PEO model, is that all three of these things come together. So there's the person, the environment, the occupation, and thinking about, okay, this person's ability is this within pediatric practice. Look, advocating for environmental supports, or thinking about, okay, this difference that they have, it's valence neutral, right? And only when we look at the occupational output do we need to kind of make those adjustments. I don't know if that answers your question.
I mean, I think yes. I was just wanting to like see if there's like other ways that we should be thinking about like the disability ethics, and I think you did answer that. So thank you.
I think another thing to think about is really looking to connect families or other sort of people that are present within that child's life with people that can speak to the experience of having disability and living their lives, because they're going to be the experts more so than many other people that they may encounter that kind of are flagged as the expert for whatever professional reason, and being able to point them in directions that may be outside of what they typically are being directed towards throughout their child's care, if that makes sense.
Thank you.
I see a question in the chat. How well do you think disability studies is integrated into mainstream OT curriculum? So I know there are people on this call that can probably answer that better than I can because they've done formal research on that. But I would say that, it's been a little while since I've been in OT school, to be fair. So I'm not sure how much that's changed since I've graduated, but I think there's always room for improvement. And I think that also, for me, at least personally, a lot of things that I've learned practicing clinically, you don't necessarily expect, or, it kind of makes them more relevant and puts them in conversation with things that you can learn from disability studies, literature, kind of having that clinical experience to sort of make sense of it is really helpful. So I'm reading through the chats, but if anybody else has questions, please feel free to chime in.
This is Laura. My name is Laura Van Pembroke. I am a white person, a white woman that has dark blonde, light brown hair. I have a beige sweater on, and I am sitting in front of my shelves and art on my wall. I want to just talk to a little bit about Justine's chat question about disability studies into OT curriculum. You're talking to an audience, at least of the folks that I know on this, that would say yes for sure. But I think that, you know, on an individual level, each of us are working hard to infuse disability studies perspectives and the social model of disability and other models that are within the disability world into occupational therapy curriculum. And I think that that would be a really valid and valuable incorporation into like mandatory standards, but I think we're very, very far from that. But I do think that when we focus as a profession on the environment and the variety of different environments, I think that bringing the discussion and conversation into, you know, using the social model as far as the mismatch and the social injustices that are created by environments that are not created or aren't safe spaces for clients that we'll be working with is where we can do that. So, you know, it's these kinds of conversations like, you know, this webinar and the special issue that hopefully will continue to broaden that perspective, and, you know, slowly but surely, hopefully we'll be, we may see that someday. That's our hope.
Lisa, we can't hear you, I don't think.
Sorry about that. Is that better?
That is better, thank you.
Okay. Hi, everyone. Sorry, it's Elisa again. We have a question in the chat about bioethics conversations that have happened around COVID-19 triage, particularly around care rationing and if folks have seen the hashtag ICUgenics. So Amy, could you speak to OT's potential role in these conversations, or even something like the, you know, No Body is Disposable campaign, and kind of more of the current COVID-19 situation?
Sure. I will preface that by saying I'm not going to have all of the answers, but I think that one thing that we can speak to in terms of COVID-19 triage, or even, for example, you know, I'm just thinking of doing therapy with people who may have mechanical ventilation, and kind of really speaking to our role as people who can facilitate return to activities and occupation, and highlighting what you're seeing as a clinician if you're practicing in an ICU, especially with patients who may be requiring more support medically for functioning at that time. Um, and really just, I think this is something that is maybe that I feel passionately about, in addition to ethics, is really highlighting in your documentation sort of what you're seeing, and making the case for the person you're working with in your documentation and in clinical rounds, to speak to why they should be getting care, why it makes sense for you to be engaging with them as a therapist, and what you're working on and towards. So I think that's really important to highlight really what you see, because we are often the experts on function within those more medicalized settings. And I am not very familiar with the No Body is Disposable campaign, but I did just take a peek at it. And I will have to get back on answering a specific question on that because I'm not as familiar. So thank you. Any other questions, comments?
Amy, this is Elisa again. I'm just curious kind of about your experience with your medical ethics fellowship and kind of being someone with an OT background that's in a very, what I'm assuming is a interdisciplinary fellowship, right? And kind of what has that experience been like in terms of how you think OTs contributed to that conversation, what you've learned maybe from other fields, that sort of maybe dynamic.
Sure. Thank you, Elisa. I would say that it's been sort of eye-opening how, despite the fact that a lot of times physicians or other disciplines are referring people to therapy services, they may or may not have a good idea of what those look like or can do for the person they're referring. And also when there may be a need for therapy based on, different experiences people may have. I think some things that it's really made stand out to me are that oftentimes people may or may not know what the realities of a discharge recommendation disposition are, because even if, for example, they say, oh, well, this person passed therapy before leaving the acute hospital stay, they may or may not have anticipated participation changes for that person where they may have benefited for additional rehab services. And I think that's something that we can educate other clinicians about. And then also sort of having an idea of what different discharge locations sort of mean in reality versus kind of the conceptual, subacute rehab means you're going to be getting rehabilitation, but less than 3 hours a day. But at the same time, we know that a lot of hospital-based subacute rehabs are closing, and these people are going for subacute rehabilitation in typically a nursing home. So what does that mean? And as clinicians that either have worked in multiple settings or are familiar with those settings, I think we can really bring more reality to those conversations about next steps and function beyond the hospital stay or whatever referral point there is. And then two, I think that one thing that also came out for me is how we may still need to do a bit of work in sort of convincing other disciplines that activity is not always, but can be quite good for people independent of sort of what their medical status is. If they're medically safe or appropriate to engage in occupation or activity, then it makes sense for somebody who's trained in doing that safely to work with them, especially if there is concern over how to do it safely. So kind of just bringing our perspective of supporting occupational engagement to these discussions, whatever that may look like, is really important because not a lot of other disciplines bring that.
Thanks, Amy. Yeah, we have another question in the chat. This is Elisa again. I love your mention of mindful reflection before action. I work primarily with adults with recent amputations, which can involve very vulnerable conversations about what their life will look like post-discharge. Would love to hear how you center yourself before these conversations or even recognize when the patient may be ready to talk.
So I think that it's going to look different for every clinician, of course, because we all have our own styles. But I think really for me personally, I try to not talk necessarily about my life and ask, well, what are you concerned about in going home? And, or, what does your typical day look like? Or, just get to know them and then see really what they want to get back to, doing their occupational profile, as cheesy as it sounds, can really help me put aside what I see as like necessarily important for them to work on, even if those things are important for them to work on eventually, but kind of, understanding what their priority points are, and then also having in the back of my mind as a clinician, okay, these are the typical topics in the case that you're bringing up that I would discuss with somebody who's had a recent amputation. When can I integrate those in? Are they appropriate? Is this relevant to my patient at this time? And in a few of the places that I've worked at, I've been lucky enough to have a healthcare system that had a pretty robust peer mentor program set up, which I know is not the case for every institution. But, even just casually bringing up the point like, oh, I'm not an expert in this. This facility offers this program. I can refer you to that. Would you be interested? Really kind of presenting it as part of the menu of things that are available to them. And if they say no, and then say, okay, well, just, it's there. And that's fine. So I think that the other point too is like kind of getting out of my head, what do I think that this person's day should look like? What equipment I think that they need to use, or whatever it may be? Because sometimes I think you can get into that point of thinking, okay, well, I need to tell them the safest way to do something, or they shouldn't do this because it's not safe, or this is a better way, this is more efficient. But kind of working together and sort of thinking about how can I support you in making a decision that's right for you as far as the plan for managing whatever occupation you'd like to do upon discharge. So hopefully that answers your question. Then I got another question in the chat that I'll read out that I think was just to me. Can you say more about disability studies? While people and professions attempt to integrate, I don't believe there is true integration. It may be valuable just to talk a little bit more about disability studies. So that is probably a good thing to do. And I know there are many disability studies scholars on this call, so please join in to give more detail than me. But I think that just like a quick little tidbit that I think is a really great starting point for thinking about this stuff is really highlighting the social model of disability, which situates the culture and the environment as disabling versus disability being a result of an individual's body structure or function. And that's a very brief intro, but I think that's a really good starting point for understanding that. And in a lot of ways that challenges some interventions within OT, because a lot of times we focus very specifically on the individual and maximizing different individual skill sets, which has its place. But I think kind of more globally thinking about both the person and the environment is always a good thing. So. Yes, Bill, I agree.
So Amy, I just want to, this is Laura again. I just want to go off what you said a little bit, because I do think that's a really valid question. I think that we could probably talk for a really long time about what is disability studies and its value to the profession, and how we weave it in. In our mindset as a clinician, as well as in our mindset as either an academic or a researcher or whatever. And I've, this is an evolving, it's never going to end. I'll be on the very last day of my life and I'll probably still be thinking about this. But at least for me, when I'm talking to students and I'm talking to clients, I really say that occupational therapists, we have been trained and we work on two different things. We work on client factors, so people generally want to optimize, their capacity to function. And there's a very huge dialogue within the disability community that the social model has swung too far or it's only looking at the environment, which that there are issues that are completely something within the person that creates disability. But then we've got the environmental element of it. And so we're a great profession to be able to really look at both sides. And so I say that, we've kind of got our foot in two buckets. We do want to optimize potential capacity of clients. And so we can work with them to identify areas that they can work on, but that we fall short of medicalizing a person. We don't just perpetuate or perseverate on that we also, and I call that working on the impairment. And so I, in my mind, distinguish between impairment, focusing on the person's capacities, and disability being what's been layered upon the person's, and the mix match between the environment and the person's capacity. And that's very often the constructed world, or the social world. So in my mind, at least right now, that's one of the ways I use disability studies to inform my practice and my research and my teachings.
Anybody else want to chime in? I don't know if there's any other burning questions or comments, but thank you, Laura, for helping to supplement that. There's a question from Lindsay in the chat, and I will just read that out for everybody. Would you be able to speak to how your current program is impacting the way you conceptualize the language of disability, specifically how individuals prefer to label their disabilities? How do you feel this connects to OT and your knowledge of labeling disabilities from your OT training and career experience? So I have a lot of thoughts on this. So I think the first one is that Kathleen Bogart actually does a lot of research about who self-identifies as disabled. And I think it's really relevant because, if you look to sort of how the census defines disability, there are a few different ways. And I probably should have this memorized, but a lot of people that would fall into the category of disability according to those census categories, whether it's there's a lot of impairment built into the way that's structured, like vision impairment, hearing impairment, and then also difficulty with performing, I believe, ADLs basically. in the census, but people, I forget the percentage, but it's quite a low percent that identify and would self-label as disabled, even though according to those categories, they would be considered disabled within the census criteria. So I think that that's something to keep in mind, is that it's, you know, it's not necessarily an identity that people would be accepting of or self-label, even if, you know, they may be considered disabled by the community at large, by you know, everyone that engages with them in public. And then another thing that I would like to refer to is, let me see, I believe it's in my reference list, but I'm not sure. It's an article by, no, it is not, but I can put in the reference by Anjali Forber-Pratt about the role of rehabilitation professionals in fostering a positive disability identity for patients. It's a very good read, I think. And, you know, I would say that it's not really our role to define anybody's identity in any context, really, but I think that what our role can be is to sort of, you know, convey that there should not be a stigma attached to being disabled, and that, you know, it's an available identity to people, and really helping them to navigate whatever they want to be their identity journey. You know, nothing about our identity as humans is really set in stone throughout the majority of our life. So it's not like people need to reach a certain identity category to really feel like that's right. But, and then the third thing that I think people can read, and I'll make sure that all of these references go in the chat, is Carol Gill's work on disability identity and sort of stages of disability identity. So I think those readings have really influenced how I think about that, in that I don't necessarily feel like I need to make my clients, my patients say, oh, I identify as disabled. You know, that's not my role. But I think that communicating that disability is not necessarily inherently bad is my role as a clinician. You know, sort of discrimination against disabled people, yes, that's bad. You should not accept that. But having a disability is not necessarily, you know, that's not inherently a negative thing. So yes, I think that is correct, Jenna.
Amy, I just want to chime in. This is Jacqueline Kish. I use she, her pronouns. I'm a white woman with dark short hair, wearing a white top with tortoise glasses. And I just wanted to comment, you know, that one of the things that I do often with clients that I think is really important is to start to talk to them about ableism and what that is, and give a name to the discrimination that is pervasive in our society towards people with disabilities. And so I think that that's something that's been very helpful for me as I'm reconciling my identity as an OT and a disability studies scholar, is thinking about that and the ways that I see it play out with my clients, and then also the ways that I can gently, carefully talk to people about it, and just sort of see what they think. Because a lot of times I'm encountering people with a newly acquired impairment, or sometimes people with a chronic condition that, you know, they're sort of saying, I can use a wheelchair. It's okay for me to do it, but I don't like the other people that do it. And so there's this complicated conversation that often emerges where I'm careful to ask questions, right? Because I'm hoping that they think a little bit more about and also help me think a little bit more about my place in perpetuating or working against ableism. So just wanted to make that point.
Just reading through the other comments. So Elizabeth Webb says, how can disability ethics be fostered through occupations, using occupations as the focus rather than individual client and their client factors? Can empowerment and self-advocacy be found? I would say yes. And I think that it really drives home that as a profession, we should focus on occupation. And like Laura said, you know, of course, yes, we should maximize individual like capacity as much as appropriate for that person, but at the same time, really focusing on those occupations and how the person you're working with can engage in the occupations that they would like to do is what we want to do as a profession, right? That's kind of the point. Any other comments, questions? I know it's been just about an hour, so.
It's Elisa again. Amy, I just wanted to also touch, I guess, kind of go back to something we were talking about a little bit about, you know, disability identity. And I think something that I am faculty at an OT program, as some of you know, and something I've been thinking a lot about is our own, I think for a lot of folks, it's one thing to talk about disability identity and ableism with a client. It's very different for some folks when we're thinking about our colleagues and future students and who gets to be an OT. And I've kind of seen this going on, particularly we're in admissions kind of season. And then even also when students come into our program, this idea of some faculty really feeling like this student needs too many accommodations. They have too many disabilities going on, and you know, they kind of throw their hands up. And I'm sure this happens at many programs. And so I think it's a conversation that we need to have on multiple levels, right? We also need to really think about disability among OT students and OT practitioners and OT faculty, and how we identify or don't identify, or maybe are scared to disclose our disability status for a number of different reasons. So I think that's a part of the conversation that I've been thinking about.
Another interesting question in the chat. What sort of conversations do you feel like are going on among OTs and disability ethics on the international level? I am not an expert on the international level. I would say as far as occupational therapy practitioners, I wish there were more conversations on this and that were framed in an ethical, like within the context of ethics. One thing that I found interesting as a part of putting this article together was that, you know, I kind of looked through AOTA and what they have tagged under ethics, and they had a special issue in 1988, which is as old as I am. And that was kind of, you know, there have been other things that have come out since then, but that was sort of the biggest discussion that I saw of ethics. And it did touch upon disability issues within it, but, you know, obviously it's been some time and some of those considerations have, I'm sure, changed over the course of that time, though a lot of it is actually relevant and interesting to read. And so within OT, I think that there is more conversation to be had, and I see a lot more coming out that at least attends to disability studies within OT literature. I mean, I don't think it's pervasive just yet, but I think it's getting more attention. And I hope that we can spend some time thinking about the issues that arise from a vantage point of ethical consideration, because as many of my mentors throughout my academic education so far have said, ethics is everywhere, because it really is weighing sort of what should I do, how should I approach this situation. And as far as the international level, I'll be very honest, I have very little knowledge of that. From what I've found, there are certain resources, but I can only read English, so I have that as my limitation in really delving too deeply into the literature from abroad. And I think, Jacqueline, do you want me to just read out the question?
It's up to you. I just was thinking of a sort of wrap-up question, but I want to give everybody else a moment to ask any additional questions if they have them. I also just want to read off that Aster went ahead and said that our next conversation, it's in April. It's about experiences of disabled women in Sierra Leone. So that should be a great conversation about international perspective. And again, that link is earlier in the chat. Elisa posted it.
Go for it, Jacqueline.
Okay, so I just have a wrap-up question, and I've been thinking about this the whole time. The whole reason that our group got together is because we were really interested in looking at disability studies and OT. So I really liked hearing about the differences between disability ethics and bioethics that you kind of wrote about in your paper and also talked a little bit about earlier. And we already talked about, and Laura had chimed in about how we're pretty far from integrating disability studies meaningfully into ACOTA standards and OT education in a meaningful way. And so in your opinion, if we're thinking about disability studies and OT ethics as they stand right now, in your opinion, what do you think needs to happen for the OT field to better integrate disability ethics? And as a group here all together tonight, what can and should we be prioritizing if we're interested in disability ethics moving forward into our field?
Big questions, Jacqueline. I like them, but I think that
dream a little bit, right?
Yes, exactly. So I think that one thing I would say is necessary to think about: how do we better integrate disability ethics into our practice as occupational therapy practitioners, is really spending time identifying ethical issues within our practice. Because I think that, for me personally, we talk a little bit about the code of ethics in school, you think about it, but then when you're in practice, at least for me, I would get those kind of uncomfortable feelings when I really didn't feel like things were best laid out for the person I was working with. But I don't think I spent the time to reflect and really identify what ethical distress I was feeling in those moments. So labeling them and being able to articulate those ethical concerns that come up in practice is a really good first step, even if that's just on your own, reflecting on them. And then kind of spending time thinking about, okay, what factors come into play in this ethical issue? What are systems level issues making this a problem? And really kind of analyzing the situation pretty critically to see what the actual issue is, and how you think you can or should act. And I think too, when it comes to treatment planning and goal setting, really being willing to give yourself a full menu of choices as far as intervention, even if the person you're working with doesn't necessarily pick what you think would be an interesting intervention choice. Just like in the case study presented in the article, it it's not so much about what the end result is. It's that the clinician took the time and reasoned through all of the potential outcomes versus saying, okay, you know what, this person I'm working with said they would like to go to the nursing home for rehab. That's an appropriate recommendation for them. I'm okay with that. But really thinking about what not only can I do, but what should I do, could I do, even if that's not what's going to come to fruition for this individual person. I recognize the pragmatic concerns that are part of everyday practice and that we have a lot of work to do in that area. And as far as prioritizing disability ethics moving forward, I actually, in preparing for tonight, stumbled upon AOTA's guidelines for having occupational therapy, let me find the exact title, ethics rounds in practice. And I don't necessarily know that many facilities will implement this, but I think that at least the structure that they laid out for conversations is helpful and is something that could really just help us as clinicians think more critically about what we're doing and, kind of think about, okay, well, why didn't I think of this, or what could I think of that goes beyond just implementing intervention at the individual level. And even if it is just a conversation with your client while they're doing something that's a little bit more biomechanical, that kind of raises their attention about, hey, there's this other resource outside of my usual approach, I guess. And I see there's a lot of chat stuff, so I'll catch up on that. But if there's any last comments, concerns, questions, please chime in. Yes, I'm going to agree with a lot of what's in the chat. And I would say a starting point is read everything that was in my reference list for the article. That's another good starting point because they're very good resources.
This is Jacqueline. Amy, you also forgot to tell everyone to cite your paper too, right? That's like one of the things.
Yes, everybody who chimed in on the chat has additional very good suggestions for what you can do to really integrate this in. And I think that showing up here and being willing to think more about this is also, a good thing to do. Really, the more I think that we as clinicians identify that every part of our practice is really an ethical decision making process, whether we see that or not, is an important thing to do because we are serving our clients and really exposing them to a lot of ways to engage in occupations that they may or may not be familiar with. And I think that we have a lot of power to do that well.
Thanks, Amy. This is Elisa again. There is a question in the chat kind of related to that in terms of thoughts you have about getting disability studies ideas more incorporated into ACOT standards. And I will give a little bit of history. Some folks on this call, we gave an effort when the last standards were kind of coming through, and there were like talking and listening sessions at some of the conferences, and we wrote up ideas around standards that were very disability studies influenced. And correct me if I'm wrong, anyone else who was involved, but I'm pretty sure none of them got incorporated. Yeah,
There were a couple very light language changes. and I can't remember exactly what they were, but there were some language changes. And, you know, in the future, we'll be on it. This group will not be going away. So when we come across the next revision of the standards, we will be sending out petitions, and that's what we did the last time. And, you know, voices can be heard. So I think that that's an important thing to continue this conversation, to continue these connections and the networking. So when that next revision comes around, definitely we will be on it.
We'll have more signatures and people power the next time around, right? And Amy, if you have, I don't know if you have any thoughts about the standards and kind of.
You know, I am not as familiar with ACOTA standards as I could be, not yet being an OT educator formally, but I think that outside of what the standards say, you know, if you just as much as you can, even if you're not in a faculty role, like take on that challenge to yourself, even if it's just like reading one article a month that you think would be relevant. You know, we can kind of at least change our perspectives to the extent that we can, and practice from a position that has at least tried to take in and incorporate these topics as best we can. So start small, I suppose, and then hopefully a coat will eventually follow.
This is Jacqueline again. Part of the follow-up to that question is that there were some professors who did a great job offering exposure and support, and classes are almost over. And so my response to that is that learning about disability studies continues as long as you want it to, and as intensely as you want it to. And so I might recommend connecting with the disability community, connecting with disability self-advocates. And we learn, but we're OTs, and we know that you learn by doing, right? And so, you know, activism, being an OT and an activist working with the disability community has provided, you know, myriad of learning opportunities. And so it's been a real pleasure to collaborate with disabled folks in the community. And so I would encourage you to think about that into your future career.
I don't know if Elisa, do you want to do any last wrap up so that people are oriented before closing out?
Yeah, sure. Thank you, everyone. And thank you, Amy, first of all, for kind of, getting us going with the discussion and talking about your work and your fellowship and all the great stuff you're doing. So we really appreciate it. And I really enjoyed the conversation. I hope others did as well. It was great to hear from a lot of different folks from working in different practice settings and different kind of stages in their career and that sort of thing. So thank you again. We did put some things in the chat. We do have a Facebook page as well as a Twitter. Our handle is OTDS Network. And, you know, we're always kind of looking to expand. So keep an eye out, you know, we're making moves. And again, we are having a series. This is the first in a series of conversations. So we will be kind of coming back together in April. So we do hope you are able to join us for that. And again, we're hoping we're going to post this video to, we have a YouTube channel now. And so we'll send the link out to all of our registrants. So you can access the video because it will be unregistered. So again, thank you all so much for joining us. Lots of thanks in the chat for you, Amy, and for everybody for, you know, their contributions to the discussion. It was great. So have a great evening and take care, and we'll hopefully see you soon.